Alrighty. So this first part here, and I think I shared this with you guys earlier, that we've got in our department, we got about 6 guys who, for whatever reason, have kind of decided, I'm not going to do any charting whatsoever. Whether that's somebody else's job, I'm a captain, I'm a driver, or whatever. I tried to sit and think about the best way to handle talking about this, and in the end, I've just kind of let the department standard be the guide. So if you're one of those 6 guys who don't chart for whatever reason, it might be that I'm an EMT, that's a paramedic, I'm a captain, that's somebody else's job, I would just present to you that you're outside the norm of your peers. The rest of the department is charting, and we have a few guys who've decided not to do that. To take that thought process one step further, for me personally, I didn't have to do a fire report until I was getting paid to do a fire report. That was the first one I did, and I was on the phone with Chief May quite a bit as I was trying to figure out how to do this report. And I know the standard, and I think this one is probably about 70%, and I'm just merely throwing out this idea. Probably about 70% of the crews do this, where the captain will just write fire reports, and that's all he writes. And everybody, the other 2 members of the crew, or 3, do the rest of the EMS charting. And I feel like we could perhaps do better. That the first time we're asked to write this fire report, the first time I was asked to write this fire report shouldn't be when I'm getting paid to do it. I should know how to do that beforehand. When we hire a new guy, we have somebody sitting in the chair right next to him at his computer and walking him through, holding his hand as he kind of learns how to write a medical report. I think we should be able to offer that same service to all our members, that eventually we're going to have Captain Mangun, and he is going to be amazing. But the first time you write a fire report shouldn't be when you're getting paid for it, that you could sit down with your crew and with your officer and be shown how to do that. So I would throw out that perhaps the rotation of one person doing all fire and no medicals and everybody else doing medicals and no fires maybe has a little bit of room for improvement. Not only should the captain know how to write an EMS report, so that way when a new guy comes on and has a question, he's able to field the questions that come his way. But then also, we're training our guys so when Captain Mangun is here, that he will be proficient in writing a fire report and have been trained and taught how to do that via his officer. So that one's just, I don't want to tell crews how to run their crew, just some food for thought and the ability to perhaps do a little bit better than what we currently do. So with that being said, there are several members who don't have their login information to ESO, roughly about 6. Does anybody here need that information? All right, and for those of you viewing at home, if you need that, please email me. It's very easy to get set up and reset and rolling. And without further ado, we're going to roll in on this thing. So that was your home page. Let me go back to that real quick. On your home page, you can get messages here from the QA/QI department. At first, they were going to be using Outlook, but they've decided they're going to be communicating with you via here. So if you have a call that you had wrote and there was some issue with it or some concern or a good job, you're going to get a message much like an email from, with our shift here, A shift, it's Zimmerman right now by himself. We'll be looking at getting more people filling that spot. And then the message and the date he sent it, and it'll just kind of fill on up here. As you get a message, if you want it to go away from here, then you just reply, at which point then it goes over to Zimmerman's home screen and it sits on his home screen. It doesn't get deleted. There's no delete. There's no hide, any of that stuff. It's here forever. There's different type of modules that pop up here. EHR is the one for writing reports. QA/QI, those people got another one that shows up, and Chief Jackson has quite a few that kind of stack up along there. Mine just has the one. So this is your landing page. As we're going through, we're going to be following in the blue book. Each station should have 2 blue books. Unless you're at station 4, you get 3 blue books. You guys are really lucky. Station 1 also has 3. I don't know how you guys got 3. Maybe one of the stations only has 1. But this blue book, there's four tabs in there. The first one is a billing tab, and then ESO tab, then billing, then dispositions. There we go, dispositions, and then QA/QI. So the ESO tab, that's the copy that everybody has gotten a personal copy of. This class is written, it was written by Smith. This is the shout out to Mr. Smith. When I first came into training, it was identified that we should get an ESO class. And Mr. Smith impressed me when I was his preceptor. It was very quickly apparent to me. I'm like, oh, he's way better at this program than I am. And so when it was identified to get this class, I went to Matt and said, hey, can you write this class? And my intention was for him to present it. And grabbed the whole department, and off we went. That was decided we'll have myself do it. I think having an officer come at it maybe has a little bit different value than one of our newer members. But he did really a bang-up job. And so as we're going along, then I'll be following from this ESO book. The book also has in an effort to make it relevant. The first 2 pages is our contact roster in the blue book. And so they're just in protective sheets. You guys can update that type of stuff. But our goal was to try to make this so it doesn't just end up in a drawer somewhere, but that it's actually used and relevant and out. Page 3 is Canyon County's contact roster. And so I don't know how we're going to keep that up to date at all. But that's their current list, and we're all aware it changes on a weekly basis. My thought is every quarter reach out to Canyon and say, hey, can I get a current list? And email that out to the crews and have them update their books. But that's in an effort to try to keep that sucker relevant. So as we're going along, we're just going to follow in the from the guide here. So our landing page, I'm on page 1 in that ESO tab. Every call that your name is associated with that is incomplete by default pops up here. So I'm associated with this call on Chicola, delete me, is the patient name. As I add crew members, then it would show up on their landing page. So as Engine 4 and Engine 3 went out, when the person starts doing the report, as he adds all 6 of the crew members from those 2 units, then all 6 of those people then would get that one call showing up on here. This green thing means it's unlocked, and when it becomes locked, it turns to black. You have the ability from this page, whether locked or unlocked, to attach documents by hitting that guide. There's a couple places to hit attachments, but while I'm here, I'll show you this one. So you hit this attachments, and then you can get into attaching files. And we're going to talk about that towards the end of class. We've got filters here, and with this filters key, you see right here, it's just the drafts and mobile that it's attached to. But if I were to also include all locked reports, by default it's 90 days. I could have it say 100 days, 5,000 days, whatever. I don't know how big it can get, but I can do quite a bit. But by default, it's the last 90 days. All calls, whoops, hit OK. All calls, whether locked or unlocked, that I've been associated with in the last 3 months are all right here. And so if you came and wanted to add or append or something like that, once a call is locked, like these guys are showing, you can't go in and edit it. All you can do is add to, but you can't take away from your narrative. Down at the bottom, you've got 2 buttons, a new record and a CAD Import. This is a cool Smithism. There's a couple that as we've been going through, but there's been several times that crews will accidentally open up, hit this A, new record, or B, they'll go to CAD Import, but then rather grabbing, for example, we've got 3 units that went to 11th Avenue North right here, Engine 5, Engine 3, and Engine 1. Rather than grabbing the correct unit, say you guys were Engine 3 and I accidentally clicked on 1, then that would be importing the wrong information. So you could either mess up by hitting that new record button or the wrong call, but you identify the call you want. You can change this filter here to eliminate on that, and you can just see Engine 4 calls that need to be done still. So you find the call you want. I'm going to go to this one that I've been using for teaching. And if you were to make that mistake, either new record or click on the wrong one. You can fix that. Now this is going to change everything that CAD imported. So if you were all the way done, had written your narrative, and you were done with the report, and then realize, oh crap, I've written this as engine 3 and I'm engine 4, then you can fix this. It's not going to delete your narrative. It's not going to delete your patient demographics. What it will change is all CAD import stuff. So we go over here to this CAD Import button right next to the incident number. And if you see this hyperlink, it says click here to import a different CAD record. You hit this click here, and now you can choose the correct call that you should have chosen the first time. Now that works with both new record or you hit the wrong one. Questions on that? Cool. All right, so this first part is pretty self-explanatory. CAD import gets most of it. The run type, 911 response priority, this is what you did, not what dispatch told you to do. Your shift, responding from, this is the map code. This will be the signal. I've always been kind of frustrated with this one because it doesn't seem useful demographics, and we're just filling out a form. But I trust that there is a reason for having us fill out this X21 or whatever the map square is. Who requested? Patient, family, bystander. This is kind of where I introduce the concept. If you have information, document it. And if you don't lie, don't make it up, just leave it blank. So if you knew that the patient called for you guys, then click patient. You knew the family called, then click family. If you don't know, then leave it blank. And that theme is going to go throughout this entire class. If you have the information, document it. If you don't worry about it. Location type. So this is the scene. This is where you went, whether it's their home at this address, or if you went to, there's a million different places, public building, industrial, dialysis. And here's that other map zone that you would enter in. MCI, this isn't, we had 2 patients on the interstate. This is actually overwhelming your resources that are there. And then their triage classifications for that MCI. Personnel. So you're going to hit on this add crew. And as of these last few months, I've been working a lot with Nick and Alfred. They're just on top. And Dr. Peterson, the umbrella of, if you have the information, would like you to document it, would like you to document Canyon's crews, if you have that information. So we would say we are out there with Rachel and here, Dan Bates. We'd hit OK. They all get added in there. Now, I don't know why ESO calls the lead the lead. In reality, the lead is what Firehouse calls member making a report. It is the person who's sitting in front of the computer screen is the lead. It's not the paramedic. It's not the captain. It can be. It's not the driver. It can be. It's the person who's writing the report. Then if you want to delineate further and say the driver, you can, or you can just say that everybody else was an other, like so. For non-crew, this is, we show up at Skyview and the trainer is holding C-spine. If we get the trainer's name, then we document it. We go on a 1050 and there's an RN helping out. If we get the RN's name, then this is the appropriate place to document that. There's another place if you don't get the name that's more general and not as detailed. Cancel. If at any time you make a mistake and need to delete it, these 3 little lines here give you that option. And I just kind of keep a clean house as we're going along in the class. And so I delete as I go. Question on personnel. Crew, non-crew. All right, dispositions. This is the meat and potatoes of the whole class right here. So it's good, it's at the very beginning. As I click on this other tab right here, you'll see this list. In the plastic blue books, not yours, Sean, because you just got the paper version, there is a tab labeled dispositions. You'll notice that one in there. It's the 3rd tab, I believe. On there is a list We got an email, what, 2 years back from Jackson that said, hey, this NFRS code gets an ESO, this NFRS code gets an ESO. It doesn't work in the opposite direction, saying this NFRS code or this type of call gets this NFRS code, right? For example, a 321. You'll notice a 321 is the very first line there under assist. In the middle is where it's got the NFRS code. Also, patient care transferred has a 321A, right? They're both 321s. So let me present our typical call, and they are about the same. There's two types of calls as most of our work. We show up just slightly before Canyon. We ask a few questions, take a set of vitals, transfer care. Or show up with Canyon or just after Canyon, ask a few questions, take a set of vitals, and help them out to the ambulance, right? It is nearly the same call. There's just one minor detail, whether we were there first or whether we were there second or at the same time. If you have information, document it, okay? We'll leave that patient's house where we show up at the same time as Canyon. We usually leave with the pink slip, okay? But that would be an assist, meaning the patient was never ours. We show up a minute earlier and it was our patient at some point, then that's a patient care transferred. Now, whether we click this or this, the report is nearly identical, right? It is just a slight variance, or should be. Now, assist does not require you to enter the patient's name. It does not require you to enter in any vitals. You could click this assist and then skip straight to narrative and write in, help patient off bar stool into car, engine 1 cleared the scene, right? And it would check all the boxes that are required, but leave a lot to be desired as far as what a good report would look like, okay? So even though something is not required, Dr. Peterson would like to see us, if you have the information, to document it, okay? So we're there at the same time or just after Canyon. That's an assist. We're there just before Canyon, or before Canyon, it was our patient at some point. We transferred that patient over. That is 90% of our work, right? Every now and then, we're going to do a call canceled, no patient found. Those come along. These last two, this would be, there's two instances when a chart that we write will generate a bill. Two times. One, we show up for a code, CPR in progress, whatever, and we take over as code commander, and we take that code commander status all the way to the ED. Canyon shows up, we're going to retain ownership of this call all the way to the ED. Canyon's going to go home and write a very simple assist chart. They will not have enough information for billing. We will write the report that has the information for the billing department. Now, I've had quite a few questions going, I didn't know Napa Fire bills. We don't. Napa Fire does not bill, but you guys are not a Napa Fire agency, and I know that is blowing all kinds of fuses here. I don't know if anybody recently certified or can think back to the last time you certified. Your agency affiliation was not Napa Fire Department. It was Treasure Valley TVEMSS, Treasure Valley Emergency Medical Services, right? So that's your agency, and we've been that since 2011. At that time is when we started getting restocked from Canyon, right? Canyon, they give us everything. We don't have to buy very much of anything. It's because that billing department, the TVEMSS billing department, bills, and then they divvy out supplies mainly to Canyon, but then Canyon then will give it to us to recoup the cost. TVEMSS doesn't pay for personnel, just pays for supplies. And we have the two times. The code commander, the second instance is when we show up, we treat a diabetic, they sign a refusal, and then we leave them at home. So that bill, or that interaction, will also generate a bill. Now, poor widow Mrs. Smith that just lost her husband, I'm told, will not be receiving collection agencies and that type of stuff for our code commander chart. I'm told what they do is they go for any insurance money that might be there and then write off the rest of it. But they'll bill the insurance for Mr. Smith who doesn't make it. Yes, I'm still here. So these two here on the bottom, I can't see you ever doing transport, no lights and sirens, but you could be transported lights and sirens. This is not what happens to the patient eventually, but what happens to the patient while it's your patient. So if you were code commander, then it would be your patient. We're probably going to transport lights and sirens. So at that instance, while it's your patient, it would be transported lights and sirens. But if you showed up on scene, gave it to Canyon, and Canyon then transported lights and sirens, it is still patient care transferred because that's what happened while it was your patient. Questions on that disposition? Because that has always been kind of a source of questions, confusion. When do I do this? Because they are nearly the same. We're coming out with the same information, but the reports aren't requiring it. An assist also could be show up on scene for a 1050 and spread some kitty litter. We don't see a patient, we don't talk to a patient, we don't have anything. If we were to make patient information required, then how would you fill out that report on that interaction? All right. Disposition. When you click on one, then it will ask you for where it was transported to. If you know, put it down. This is the service of while it was your patient, not overall. If Canyon, you think they started an IV, don't guess that it was an ALS call. If you started the IV, then it's obviously an ALS call. I think you asked that question last time we were here. We're not padding the stats at all. It's just do what it was while it was your patient. So destination, this is be your hospital name. Trauma registry, this is a big deal with Canyon. It's actually in December's class. We're talking about that trauma number. It's not as big a deal for our perspective from the fire department. But if you do get that actual number that is put on that patient, then this would be the appropriate place to record that. Times, this is just guesstimations. We're not looking for radio at patient and radio transfer care, but those are the two things that are needed at patient time, and then transfer of patient if you transferred that patient to Canyon. If it was Canyon's patient the whole time you were there second, then obviously you'd never transferred that patient. Okay, dispatch delays really doesn't have that much to do with us. But if there was something there that happened, I can't imagine. But this response delays, this guy could be us, right? If we got caught by a train en route, especially down here at Station 4, that happens for you guys on occasion, right? Or distance, weather. Where's our weather one? There's like snow. There we go, weather, right? This is where you're going to want to document if a call should have taken you 5 minutes to get there and it took you 20, then it would be appropriate to document, hey, scene delays. Sometimes we'll arrive on scene, wait for code 4, right? So that is a big arrival on scene, but then a huge gap before at patient, right? So we should explain why it took us 20 minutes to get to the patient. So we're waiting for code 4, or you guys probably don't ever have, oh, there we go, law enforcement assistance, patient access delay, or where's the nursing home one? There's a nursing home one, I know there is. Maybe it is this access delay. Show up at Karcher Estates, nobody even knows you're coming. You go to both ends of the place several different times. It's 20 minutes before you get to Mrs. Smith with a broken hip, right? That doesn't happen. So this would be appropriate. Staff delay, I knew there was one, staff delay, right? Where it's a reason why it took us a long time to get there. Or if we had to break into their house, go through a window or something like that. That's the lockout. Transportation delays and turnaround delays, that's not us, that will always be Canyon. If you are code commander and don't have those miles, don't worry about it. They Google map it, okay? If you guys are driving, they can Google map it. But if you remember to say beginning mileage, ending mileage, I know most of Canyon just enters it in on their MDT as they're doing it. They don't actually even say anything on the radio. But additional factors. So if we're on scene with ISP, we should mark that, Caldwell Fire. The whole, if you have it, document it. If you don't worry about it. Additional responders. So this is where we would document that nurse who was on scene holding C-spine, saying, hey, there was somebody here. So you could hit healthcare, other, and now with this additional comments down below, you could say RN on scene, on arrival, right? Or whatever the case may be. All right, that's incident. Any questions there? Patient, upwards, onwards. First name, last name, middle name, soc, date of birth. It's really just their last name, soc, and date of birth. Those three things is what is, we need two of those three fields, and that becomes searchable. If you were to have a patient, I'm going to make something just off the top of my head, that maybe had an anxiety issue, 28-year-old male, out in Station 1's area that we went to all the stinking time to go see this guy, right? Eventually, you got to call it up the chain and say, hey, we're having problems here. For us, we did that, and we were told you've only been there 4 times. And that is because most of the time we would arrive and mark it as an assist, which would then make it to where we could just go straight to the narrative, skip marketing that guy's name, because we would find him at McDonald's, Fred Meyer's, Home Depot, all over the place, right? So it's super important to make sure you get that name in on patients you think, oh, we're going here quite a bit, to document that we're seeing this guy, and it's not tied to his address. There's another reason why it's kind of cool to do. If you have somebody you go to on a frequent basis, then it will automatically populate in the rest of this demographic stuff. So if you guys are always going to Mr. Fields down the road and picking him up, then you could type in Fields for last name and date of birth. Now it needs to be the same date of birth every time. It needs to be the same last name. ESO is, I'm going to say national, but it might be bigger than that. It's a big program. It's all over the place. And if Mr. Fields was ever seen in North Dakota, Bismarck, North Dakota, then it's in that database. So when you do 2 of the 3 fields and hit this search button, then it is going to pull up everybody in that database for the last 90 days. So you could sit and pull that up. Now, if it hasn't been seen in 90 days, then it's not going to be there. But if it hasn't been seen in 90 days, I wouldn't say we're going there on a high-frequency basis. But there's an option there. Now, it'll bring up all the Mr. Fields with that date of birth. And so then it's up to you to identify the right one, right? It'll have first name listed, but that first name isn't part of the searchable criteria. Search name, you click on it, and some of them will have better medical histories than other, that type of stuff. I think the big reason for that demographics that we should be doing that is for that future searchable, you guys are there all the time, or no, you're not there. Okay, but it does have that ability to pull in their medications that are entered and all that stuff. Age fills in automatically once you get that date of birth, or you can guesstimate their age and hit that estimate. Weight, it only allows you to guesstimate to 1 decimal point, which I was kind of disappointed with because I'm not a super good guesser, but I am really, really accurate. 178.6 pounds, everybody, or whatever, right? But this is just a guesstimate of their weight. It really, nobody's checking or anything like that. Where this really plays in is for the paramedics. Make sure that this weight then is coincides with your medications, and that's why it's a required field, is we have some medications that are weight-based. PD color coding. This is for your Broslow tape. If you have a PD code. Male, female, this is kind of cool. Did you know there was an unknown? I didn't know that. Begs the question, if there's an unknown, why didn't they just, of the 3 speed keys, there's only 3 options rather than other. Just make the other say unknown. There's a ton of different races and then ethnicity, Hispanic or not Hispanic. Okay, contact information. If we go to Mr. Fields and Denny's, treat his diabetic issues, treat and release, then a bill would be forthcoming from that one. If we don't write down his actual address, then there'll be no way to collect any revenue on that. So oftentimes this is copy scene because we are at their house. But if we're not at their house, then it would be appropriate to document their address, and this is where that is done. Phone number, driver's license, if you get it. That's a lower frequency, although phone numbers are pretty common. Physicians. So the pink slip comes in, right, and it's got their physician name on. I would add it to my narrative. I was a super heavy narrative writer, but that makes it then where it was theoretically documented, not at all in a usable stage as far as being searchable, indexable, that type of stuff. So as we go in on this class, you're going to see more and more that we're taking away from the narrative, and if it has a field, put it in the field. Physician's name is one of those examples. Advanced will. All right, these next 3 tabs, history, allergies, medications, As you click on one, then it gives you the ability to do all three. And just check what you know and don't worry about it if you don't. This next one was kind of cool. I didn't know it was there. Belongings. If at some point we have Mrs. Fields' purse, and we hold on to it as you get her on the stretcher, that type of stuff. We look in it, get her driver's license out, or cell phone for her, put it away. The keys. Whatever we have that's personal property, we're introducing some liability there. This is actually a required field in Canyon's ESO, that because they were having troubles with people with the purse left at the head of the bed, right on the stretcher. And so if you have any of their personal belongings in your possession, then we should document what we did. So if we were at Walmart and she told us to wait, the neighbor's coming to get the car, then we would click those keys and then we would document details given to neighbor as per instruction. It's important to document that, but if there's nothing to document, then don't worry about it. Go to delete. Questions on that belongings? I thought that was a pretty cool tab. All right, vitals. All right, I've kind of hinted on that. On this, the next three tabs, vitals, flowchart, and assessment across the top. We do not have to always do SOAP. At the beginning, it was all SOAP or nothing. You mind checking that, make sure it's still going? The recorder device, will you make sure it's still on? There's been a few of the times I've recorded this class and it hasn't always stayed on. So I'll magically shut it off. Awesome, thanks Todd. So we do not have to always do SOAP report. You can do whatever you want. You want to do chronological, do chronological. You want to do decharted, whatever. I'm a SOAP guy. It's been easy for me. That's just what I was taught on. I've done SOAP every place I've went. But it is now going to be much, much less lengthy because I'm finding a place to document out here all of my information. In the past, I documented everything in my SOAP report and left this a little more sparse. That made it to where if somebody were to search a record on me, how many times I've given oxygen via nasal cannula, I'm willing to bet it'd probably say 0. I've never given oxygen. But that doesn't mean that's the case. It's just I always documented that over there in my narrative. It was documented, just not documented properly. So please, because it is searchable, indexable, document out here as much as you can, which then makes your narrative smaller. Dr. Peterson is not looking for you to double document. So if you are doing chronological and it helps you as you're writing it to want to make a note that, hey, we gave oxygen, that's fine. Or we took vitals, that's fine. What we wouldn't want to do is I gave oxygen in my narrative. I wouldn't want to say I gave oxygen 4 liters per minute, nasal cannula with no improvement or with improvement or whatever. Just say, arrived on scene, vitals, O2, transferred care. Something like that, very general, very basic, because now over here in my flow chart, I've put oxygen, nasal cannula, 4 liters per minute. I've given my vitals right here. We had people that were documenting vitals both here, but then they would also write down the whole set of vitals over in their narrative. That's not appropriate. The fear is to contradict yourself. Just say I gave it at 4 liters and then gave it at 6 on another spot or whatever the contradiction might be. So as we dive into the vitals here, no, I forgot to delete this last time. When you pull this up, it just looks like this. Monitor import. Soon. It's going to be soon. But I did say soon back in October. And so I really hope it's soon. The Zoll monitors are currently talking to the MDT. They're up to the cloud. It's all there. Now and we keep getting these false horizons as we're saying, oh, okay, I do this, and then we're there, right? We thought we just had to get the Zoll talking to the machine, and then we'd be there. But the hang-up right now is that connection between the Zoll cloud and ESO. So it's soon, but when, I've stopped saying any second, but it could be soon. Fact is, I hit this monitor import. Nope, nothing found. There might have been something there. I wouldn't have been surprised. It's soon. But when, I don't know. Fact is, we don't use our monitor all that much, right? Canyon does. They take all their vital signs on that monitor, and it'd be super handy for them to be able to do that. For us, we're doing EKGs, right? But we're not usually sticking it on just to get a pulse and a sat. But someday this will be here. This will be handy for codes. That'll be when it's really handy. So we'd want to click on the Add Vitals. This is one, oh, I forgot to cover this back in times. This date right here is one that I would usually mess up on. If you're writing a report on day 2 from day 1, then it automatically generates the current date and time. And we all know that. But I would change this time, but forget to change the date. This is another Smithism. Back over there in the very first tab, the incident tab under your times, if you go to the first place where the incorrect date is written, when you're all done with your report, you go to that first place. Don't worry about changing any dates. So you're done with your narrative, you're ready to lock it. You go to that first place, and that first place where the time's going to be run is a patient, arrived at patient time. And you change that one date, then it's going to ask you a question, well, do you want to update the whole report? At which point it's going to go from that point on and grab the rest of it, including this guy here in your vitals. So you can go through and just update your times, don't worry about dates, and then just wait till the end of your report to update your times by grabbing it in the arrived at patient date. If you want to make sure you get the right date time, and then these 3 across the top are, and I think it's just the AVPU, isn't it? I don't think you got to do side and position. Yeah. AVPU and GCS are the 2 required fields. The rest of it is if you have it, and this is patient care transferred. If it was your patient, then you would probably know their mental status, be enough to document alert, verbal pain unresponsive, and their GCS. So that's required with your patients. It's not required if you did an assist, but if you walk in the room and you help Canyon take a set of vitals, then document it. If you don't even do that, but you help the patient stand up from their stretcher or from their lazy boy and onto the stretcher, then it's very easy to know that their mental status, right? You could document that GCS. You could document some things. So if you have the information, document it. Don't worry about getting too crazy on the ECG here, because you're going to be documenting your interpretation, that type of stuff over here in your flowchart. So scoring, and then this pain scale. This would be appropriate if we had, if you're ever giving pain management, right? If we give some fentanyl, then it would be appropriate to document your pain before fentanyl and then a second set of vitals after fentanyl. It pops up, and you got these 3 tabs that kind of scroll through the different fields that are there. Questions on the vitals tab. Flowchart. Okay. So, just to reiterate, don't double document. If there's a place where you can document it outside of your narrative, do it there. There's 2 tabs we don't want to do, and they are very popularly used. One is this ALS assessment. Why am I having? Oh, it's in the other one, isn't it? This critical care has ALS assessment, and other has BLS assessment. This would be a way we could double document, and we don't want to do that because over here in assessments, you're documenting your assessment. So we don't want to double document, so we wouldn't need to ever click that BLS assessment. That was a common one to do. If you did something, document it. If you didn't, then don't document it. And that's easy enough. This tab doesn't require, even when you patient care transferred, to do anything in the flowchart.
So you don't want us to use BLS assessment to indicate that we essentially did a BLS assessment just to say that we did it?
Because you're going to say you did it right here.
Okay.
Right? In the assessment tab.
That as a skill performed? Okay.
No. We just don't want to double document. And because you can document your assessment, whether ALS or BLS, and the difference in that being what, the provider level, right? So that is kind of cloudy to me. If I have an ALS patient, then I did an ALS assessment, or if I had a BLS patient, I did a BLS. That's cloudy on when I would want to do one or the other. The fact is you don't want to do either one. If you did an assessment, document it over there in the assessment tab.
Okay.
Whether ALS or BLS, they didn't teach me the difference between those two assessments. So I want to throw some oxygen. This is the one, our place for oxygen. Throw some oxygen on. You want to select the device, the flow rate, and then the provider. This is the guy who put it on, right? Not the lead or the member making a report. This is the guy who put it on. And then patient change. Unchanged, better, worse. You hit OK, and off you go. We got the oxygen. Questions on flowchart. ET tube is also there. This is where you're going to want to document your 12 leads, or if you do a 15 lead, right? You get that right-sided MI stuff going on, your 3 lead.
I use the C-spine clearance quite a bit.
Yeah. Yeah, because we have that protocol, and we're going to actually read it and talk about it today in the second, more exciting class. But this class has a ESO in it. I sounded excited, didn't I? Okay. Questions on flowchart? Upwards. Assessment. Does anybody here use this?
I've used it a few times.
That was my go-to button. I loved it. We show up. What's that?
She doesn't want to use it.
No. That's the segue. I would show up, and we would have somebody, we'll say, with a stub toe. Okay. So I would say their mental status was happy, their skin was happy, their heat, head, eyes, ears, nose and throat, chest, abdomen, back, pelvis. I'd leave that one blank, and then their neuros, all good. And then I'd go into this extremities and hit this assess and get detailed with their stub toe assessment. The problem with this, and I'll talk specifically towards this, but there's other things. Todd, right now I can see you've got 2 eyeballs. And I can see, you got blue eyes? Definitely can't address your pupil size. I've got no idea, right? Now, by checking this no abnormalities, I have gone in here, and I have said his pupils are all good to go, right? And I didn't assess his pupils. I have no idea what yours look like. So, with that being said, there is no reason ever, change assignment, every time it's going to pop up, for us to use that no abnormalities button. If you assess something, document that thing. If you didn't assess it, then leave it as not assessed. The QA/QI people realize, Dr. Peterson realizes, why does that keep popping up? That we are there for a short period of time. We're not doing an ICU extensive head-to-toe checking for lice physical. Unable to save. Sounds great. We're going to continue working. It'll pop up. It's that internet thing that keeps fighting me. If I had my hypothetical patient before, I would just go down here to the extremities. And I've got left arm, probably didn't check. Right arm, probably didn't check. Left leg, probably didn't check. But, oh, here's my right leg, and I can go in and say what I had going on. They're just looking for you to document what you did, what you assessed, and then don't guess on the rest of it. If you listen to lung sounds, document it. If you didn't, don't document it. There you can, I'm trying to find one. Oh, the abdomen, I'll have one. There are places where there's a third tab besides the no abnormalities. You can say soft, non-tender, at which point then it automatically hits that. And that's okay to do those guys. This one, though, not okay. In the head, you've got the pupils, right? You can just hit that perla, grabs them all. Do you have a question, Todd? If you have a patient who is, it's normal for them, but abnormal. For example, a dementia patient. They would not be combative, but they will be confused, not hallucinating, they're not unresponsive, they just have dementia, right? This is a dementia person. Then here we would type a comment, patient acting normal per family due to history of dementia. Okay, so if it's normal for them, but abnormal, you want to document why. If you have something you should assess but didn't for whatever reason, somebody complained of shortness of breath in an industrial setting, right? And so you should listen to the lung sounds on a shortness of breath call, but we didn't because we were sitting next to a potato peeler, loud machines, right? Canyon did it. So we would say not assessed, right, for lung sounds, but then down here, think of it as a note to your friendly QA, QI man, right? That I know I should have listened to lung sounds, but I didn't due to outside noise. So something you should have assessed but didn't would make a comment, or something you assessed was abnormal but normal for them. Make a comment. Those are your when to make comments. There's one other thing that's anatomical. I find this crazy handy for trauma patients. You have different models, male, female, child, or infant, and then you choose what is wrong. So if I had a child, we'll say, with maybe a burn, a cigarette burn, and that cigarette burn was right there. That would be difficult for me to describe as well as that picture does. Like, I know exactly, all right, cigarette burn right there. You hit OK, it does pop up this, burn to chest. And then I can go into these comments and try my best to describe cigarette burn, right upper chest, right? Something along those lines. So I find this anatomical handy for traumas, whether gunshot wounds, stab wounds, burns, that type of stuff, as far as documented. The downside to this anatomical is it does not print off. So if the lawyer asks for this report and doesn't have ESO, the program itself, and just gets a print off, they won't have this document. But it will be handy for QA/QI. If the lawyer gets ESO program and looks at it digitally, then it's there. If at any time you make something happen on here you want to delete, as you get that the mouse over the wound and you click on it, you'll get two things. First, describing what that circle is, and then the other is delete. Assessment. Any questions? You got your first set of vitals, and then second set is ongoing. And this assessment now is why we don't use the ALS BLS assessment, because you have documented your assessment already here with its timestamp and everything. Narrative. My old reports was a SOAP, subjective, S-O-A-P, right? So this subjective part is still going to be here in my new report because I don't have a place that I'm documenting my pertinent negatives, all the quotes that people are telling me, that type of stuff. That is what's going at the beginning. So I'm going to have an S. Next is my O, right? My objective is my assessment. I won't have any O section now. Next is my A, right? My assessment. That's right here, primary impression. It's not a comprehensive, has everything under the moon that could ail you. But there's a lot of real general things that you can kind of go up. There's not anxiety in here, for example, but you do have behavioral psychiatric, right? And that behavioral can be a huge umbrella that can grab a lot of stuff going on. So if you ever have a time when you're like, I'm not sure if this is just constipation or appendicitis, then you could go primary impression, constipation, secondary impression, appendicitis. My old reports would have said for my assessment, possibly appendicitis versus constipation, right? Like, I don't know, it's one of these things, doc, you figure it out. Their systems, it's pretty self-explanatory, medical, trauma, or both. Now, when you click on this guy, ESO, it unlocks or makes other things required depending on your answer. So this medical trauma makes this form over here, the CDC trauma form, required. When you get into here, for this guy specifically, if we have our stub toe patient that was a trauma, we should mark it as trauma, which now makes this form required. So On a stub toe, I would say, no, we didn't activate the trauma system because of vital signs or the anatomy of injury, or the mechanism of injury, or any special considerations. And then I can walk away from there. I don't have to do any more. If you were to decide to keep working and say, I don't know any of that, and I didn't activate and hit this no, then they're going to look for a reason why you didn't activate the trauma system. And there's no correct answer for stub toe in this list. So that being said, you do not have to mark that part. Just mark these 4 boxes saying, nope, 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 it was a trauma, but we didn't activate the system because it wasn't warranted, and you're good to go. I gotta delete this. I forgot to silence my phones, evidently. There's the description there of the different special patient considerations to help you remember level 1, level 2, level 3, or priority 1, 2, and 3. Narrative. Supporting signs and symptoms, all pretty self-explanatory. Chief complaint, again, duration, it's usually 10 minutes, right? They start complaining of belly pain, they call 911. If it's something different, then obviously mark that differently. Injury. Was a patient injured? This goes back to the trauma thing and then the history of that injury. I think this is, and this is speculation on my part, but that's workman's comp stuff. You know, asking about how it happened, or as far as that's where that data gets pulled to. Factors affecting care. I didn't understand that, and although factors affecting care seems to be a fairly straightforward title for something, then you're like, oh, okay, factors affecting care, I understand what that means. But just because somebody has had an alcohol drink, I would always mark this saying, yeah, he's had alcohol. Was that a factor affecting care? Somebody stubs their toe and they're inebriated. Does the inebriation affect the care? If he's compliant, talks to you, lets you know about their stub toe, is that really affecting the care? Pregnancy. Because somebody is pregnant and they were in a car wreck. This is one of the actual questions I had. We had a pregnant lady in a car wreck. She was like 4 months pregnant, not even hardly at all, but hurt her thumb on the steering wheel. So nothing to do with her belly, all about her thumb. Did the pregnancy have anything to do that affected the care? It didn't, right? But if you were to say yes, that is going to, now over here in this forms category, make the OB form required. And think about that patient with the broken thumb. Would you know any of these? You might know, right? She might tell you about her due date, but you're going to have a hard time filling this form out. But if you had a lady who was 9 months pregnant with that same hurt thumb and also some discharge, that type of stuff, now that pregnancy is affecting the care, right? Because now we've got a pregnancy issue. And so then we'd be able to more adequately fill out that section. So factors affecting care, keep going down, keep going down. Oh, it's not scrolling. There we go. If the patient is altered mental status, that could affect the care, right? History of dementia makes it hard for us to do an assessment. If the patient is severely obese, right, and hard for us to do a good physical exam on somebody that we can't really get around. Language, hearing impaired. There's all kinds of factors that can affect our care. It's not just they were altered or they had drugs on board, and that's what I mistakenly thought before. So if it affects your care, then document it. If not, don't document. And I don't believe that one's required. Narrative. I've kind of covered that. Any questions towards that end? Whatever you want, just document. Forms, we've kind of gone through all of this. Coronary syndrome, advanced airway burns, Cincinnati, CPR, vehicle, crash, OB, spinal mobilization, screening tool, influenza screening. I don't see us ever doing that one. The rest of these, they've popped up different times being required for me. Billing isn't us, although down here, second to last, there's a tab called Next of Kin. Now, when I first read Next of Kin, in my mind, that is Grandpa hit by a reindeer, splattered all over the highway, and we're trying to find Next of Kin. Let me suggest perhaps another use for this. We're at a skate park, and we call and talk to Mom on the phone for a 16-year-old male with a broken arm. Mom is Next of Kin. We would be appropriate to document who we spoke to on the phone. This is where that would be done. Relationship to patient, their name, phone number, address, whatever information you get, document. But this would be the appropriate place to document that. Signatures. We don't use someday. It'll be a magical, wonderful day. There'll be rainbows and ponies and unicorns. We will have tablets. That day is not today. I wouldn't expect it in our lifetime, probably. Maybe someday. Unicorns and ponies, like I said. But if we had a tablet, we could get signatures here. We don't have that. What we do have is this provider signature. We do that on this one screen. This bottom one, controlled substance, we do that via paper. And so if we got rid of that, then we could document it here in ESO, but we don't. So provider signature, you're going to select your name from the list. It will have everybody's name on there. So on our previous example, Dan Bates could have been one of the names that could have been picked to sign here. The only one that's required to sign is the lead. You click here to sign. Are you guys finding your signatures getting better as time's going on? Yeah? Is it? At the beginning, mine was really bad, and this mouse doesn't work really well, and I'm not teaching this class super much. I can't see, it stops. Yes, it's perfect. You guys all saw Chief Jackson's example of what a signature looks like, and whether it is a line straight through, a circle, and a smiley face. I wouldn't recommend any of that. I'm just merely documenting that it can be whatever it is. It doesn't even have to remotely represent your signature. Do your best. Sign it as you can, and if an X is your best signature, then an X it is. Questions on the signatures? So that kind of segues in to two last points. I've actually done really well. For the videotaped one, you guys at home are welcome, because this is sometimes taking over 2 hours. I'm on page 18. If you're looking, other topics to hit on, IDO Center. So the IDO Center is viewed as a shift. So the expectation is that we do our reports before we go home in the morning on our shifts at 8 in the morning. We do have all our reports done. The same is true for IDO Center. If you do an Idaho Center event, the expectation is you go to a station and document your reports, whether you go to Station 5, Station 3, or go to your home station. I would just go to the closest one. Station 5 has pretty good internet access. That's pretty easy. Whenever doing city business, you should be compensated for doing the city business. That being said, if you go to Station 5 and are doing charts at 1 in the morning, then you get paid till 1 in the morning or till 2 or whenever you get done doing charts. If I were to do an event that starts at 5 o'clock, then I would need to get that Pelican case. So at 5:30 is when I would go on the clock as a paramedic. If you're just a BLS crew, you don't need the Pelican case. But I would go to Station 5 at 5:30, get the Pelican case, make sure it's up to speed and good to go, then go to the IDO Center. When you get to the IDO Center, you need to call up dispatch and have them start an event. They're pretty familiar with it. It's just SE1 or SE2, Special Event 1, Special Event 2, if there's 2 units there. And then at the end of your event, you call up dispatch, say, hey, we're all done, please close out that call. And you drive to Station 5, and you return the Pelican case, and you do charting for however long that takes. I'm going to keep talking to the video camera. It's a good pause. This is realistic, real life stuff here. You guys go do something amazing. I'll be here eating your breakfast. No, please keep recording. I'm going to keep talking. See you, gentlemen. So if you were to do an IDO Center event and the same person picked up the case and dropped it off, is it conceivable that person then is getting another hour or even more of extra pay because they are arriving a half hour before and then however long it takes after the report to finish up the reporting after the event is over. It's no longer going to be acceptable to do it the next day when you're on shift. Scan refusals. So I think most of us have gotten this message, but we need to start scanning refusals. I'm still on page 18. Effective immediately, and we're actually doing a really good job. I've talked to Tina down at admin and working with her. If any mistakes come through, then I've just had her set up them to the side and I grab them and then go talk to the crew members that have made that mistake. So you're going to want to attach a file, attach your scan. So you scan the report into your station computer. Most stations just have one computer hooked up to the scanner. It automatically goes into a file folder called Scan Documents. You go in and rename that file into run number space refusal, or we're also getting HIPAA forms.
This is for a vehicle that is leaking fuel, say blue Honda CR-V 11090 Mossling.
So it's either run number space refusal or run number space HIPAA. And so you rename that in your scan files folder, and then you go into your ESO chart. I showed you at the very beginning how you can attach that. The other place to attach it is here. I'm in this unlocked report. I click on these three lines right here. You hit attachments, and then it says there's no attachments. Do you want to add one? I add an attachment. Now I browse. And I go to that file folder, find my call, and hit open, at which point then it's there. And you hit attach, and it is now attached to it, whether refusal or whether HIPAA. It's important to make sure you scan that as a PDF. A few crews have been scanning that as a Word doc in Paint. And then that can be edited and that type of stuff. So save it as a PDF, and that'll be one of the options, save as, and then just make sure it says PDF. And the other thing is both sides of the refusal. Make sure you scan both sides of that refusal, whether you attach them as two different PDFs or page 1, page 2, under one attachment, or Bowden. I thought this was a great idea. He copies the front and then tapes on that piece of paper, tapes on the refusal on the other side. So one sheet of paper has both the front and the back on it, and then he scans that one sheet of paper. However you do it, make sure you get both sides and saved as PDF. Now HIPAA forms. So in the book, under the second tab is called Billing. Give you a second to turn to it. That first page in billing talks about some specific examples of what you need to make sure you get. Minimum information, and then gives some examples of where a diabetic, when you transfer care, a cardiac arrest, how that narrative would look as an assist chart. The next 3 pages are instructions on how to fill out a HIPAA form. The next 2 pages, excuse me, I guess they're front and back. To boil it all down, that last page in that tab is an actual HIPAA form. And you will notice on section 1, patient signature. That means section 1 is signed by the patient. If the patient is unable to sign, then you're going to either be in 2 or 3. Section 2 being the authorized representative. If you have mom sign, power of attorney sign, whatever, if somebody else who has legal authority with this representative, then they would sign in section 2. Section 3 is where nobody is around to sign. So you are going to sign at the beginning, and then the healthcare receiving facility signs at the end. We need to get a HIPAA form on 2 types of calls. The diabetic refusals, and when we are code commanders. Those 2 times are the 2 times we need a HIPAA form. You do not need to get one any other time, just those 2 times. Code Commander, diabetic refusals. The last section in the Blue Book, labeled QA, gives you some pointers on stuff to make sure that you get if you are messaged from the QA/QI committee. Then they will reference one of these pages. I'm just going to open one up to page 7. It's talking about abdominal pain, and it talks about the minimum that is needed for a QA QI person, and they will reference, hey, don't forget to fill out the ESO exam section talking about their abdomen. So yeah, that's that last section. They'll refer to that as we go along. And with that, that's it. Merry Christmas. Thanks for the time. Happy Hanukkah.